Good evening, everyone, and welcome to Elevate, a GE Healthcare educational webinar series. My name is Dr. Arlene Siriodica, and I'm the Clinical Education and Applications Manager for Life Care Solutions in ASEAN, and I will be your moderator this evening. Tonight, we are privileged to have a distinguished speaker with extensive clinical experience. He received his Doctor of Medicine degree from the University of Santo Tomas Faculty of Medicine and Surgery in Manila, Philippines. He subsequently pursued specialization in internal medicine at the Medical City Hospital, Department of Medicine. He then took his subspecialty fellowship training in adult cardiology at the Philippine General Hospital, followed by his fellowship training in clinical research in adult cardiology in the same hospital. He then pursued further training in peripheral vascular diseases at St. Luke's Heart Institute Non-Invasive Vascular Laboratory in Quezon City and the University of Washington Medical Center Vascular Diagnostic Services in Seattle, Washington, USA. He took further training in stress echocardiography at the Hahnemann University Hospital Cardiac Imaging Laboratory in Philadelphia, USA. He subsequently took further training in research and epidemiology at the Erasmus Medical Center in Rotterdam, Netherlands. He is a diplomate and fellow of the Philippine College of Physicians and also a diplomate and fellow of the Philippine College of Cardiology. At present, he is a consultant cardiologist and a hypertension specialist practicing at the Medical City Hospital. He is also the clinical head of the Cardiac and Peripheral Vascular Diagnostic Center of the Medical City. He is a member of the Section of Cardiology Fellowship Training Program of the Medical City. He is also a member of the Council on Cardiopulmonary Resuscitation of the Philippine Heart Association, a basic life support and advanced life support trainer. Let us all welcome Dr. Albert Hans Bautista to give a lecture on improving clinical cardiology workflow with digitization. Over to you, Dr. Bautista.
I think I need to be given permission to share. Okay. Okay. Good evening. My topic for tonight would be on improving clinical cardiology workflow with digitization. And I placed as an outline, I'll talk a little about diagnosis and management of acute coronary syndrome, then a little on the role of workflow digitization. Then I'll discuss or describe the clinical features available in an ECG management system. Then I'll talk to you about a comparison of a paper-based ECG system and a digital ECG workflow. Then, as far as our present situation is concerned, I'll discuss the role of digital workflow in management of COVID-19 patients. And then finally, I will give a summary of the benefits of digitalization. If I may just, okay. Now, we know that 31% of all global deaths are actually from cardiovascular diseases, and 85% of them are from heart attacks and strokes. So that's quite a lot. And our work is pretty much a lot as far as treating our patients is concerned. And as far as the 2000 guidelines on the management of ST elevation MI, we know that performance of 12-lead ECG by the EMS personnel at the site of first medical contact is very important, so that we'll be able to diagnose immediately the presence or absence of a myocardial infarction. And so much so that a pre-hospital notification is very important, especially if fibrinolysis or pre-hospital activation of a cath lab is needed, even prior to the arrival of the patient to the emergency room. And of course, the patient should be transported better to a PCI-capable hospital, so much so that we can attain the goal of having a first medical contact to device time of 90 minutes or less. Especially since if we are going to go for fibromyalgia therapy, we should be giving it within 30 minutes of arriving in the hospital. Now, this slide just shows you the reduction of door to intervention time, which is the key to better patient outcomes, wherein the lesser the contact to balloon time, the lesser the in-hospital mortality. Now, how does digitalization of cardiac workflow play a role in the timely diagnosis of acute coronary syndrome? We know that the patient is at the site with the ambulance, and the ambulance would then now take the ECG. The ECG nowadays are usually Wi-Fi capable or GSM IP capable, wherein they will send the ECG to the hospital site FTP server, and from here they will be sent to the ECG workstation or to the doctor's laptop or tablet inside the emergency room. Hence, it will now complete the pre-hospital notification of the hospital, of the doctor. So that's very important as far as uh, facilitating better treatment for our patients. Now, this is features of the Muse Cardiology Information System, wherein it's a patient database and archive system. As you can see, this is the list of patients with ECGs done. And when you click on it, you can use the calipers, you can zoom in, you can measure the PR interval, the QRS, the QTC. You can even type in the diagnosis or the interpretation. Note that you can see already a computer algorithm interpretation. Personally, I would want to check on this and edit it if it needs editing, but most of the time they are okay. But then, of course, I'll be able to sleep better if I do check on it, of course. Uh, the matter between your ears is still the best compared to a computer. And what about patients with non-ST elevation acute MI? Of course, 12-lead ECG should also be performed, and you need to do actually serial ECG changes, approximately 15 to 30-minute intervals during the first hour to be able to be sure that these non-ST segment changes would not turn into an ST segment change, which actually gives you a different mode of treatment as far as this type of patients are concerned. And being able to do serial ECG comparison uh, uh, makes your uh, treatment of the patient better. It makes you more efficient. You have a comprehensive and complete understanding of the patient's ECG and history, and you see the changes, which helps you avoid the guesswork as far as care delivery is concerned. And this serial ECG comparison can actually reduce up to 50% false positive admissions of chest pain patients. It can reduce up to 31% ICU admissions of non-MI patients. And it increases the accuracy in ECG interpretation up to 14%. So it's very important to do serial ECG comparison. This is an example of doing serial ECG comparison using the Muse Cardiology Information System. We have a 76-year-old male, came in because of chest pain. The initial ECG, which is usually the bottom part, and the latest ECG is the top part. In the bottom part, you can see it has it's sinus bradycardia with first degree AV block and inferior MI with reciprocal changes on the septal lateral walls. When you look at, so that's on admission. When you look at 10 minutes later, there are actually additional changes on the septal and lateral wall, which makes you more aggressive and not just watch the patient. So much so that at this point in time, the emergency room physician decided to give fibrinolysis at that point in time. And this ECG, which is 4 hours, well, 4 hours, 40 minutes later, as you can see, the fibrinolysis work. There's uh, the lateral septal wall changes are mostly back to normal. Unfortunately, the inferior wall is already injury or Q wave already, but at least we were able to prevent with the timely intervention of the fibrinolysis because we were able to see the serial changes in the ECG. This is another case. On admission, again, we see inferior MI with reciprocal changes. 25 minutes later, actually, the patient refused PCI. So fibrinolysis was started. However, 31 minutes after the fibrinolysis, the patient went into SBT and cardiogenic shock. So they were finally convinced, okay, let's go for PCI because it's an emergency. And 4 hours post PCI, I mean, 4 hours later, which is the ECG immediately post PCI, you can see you have improved the lateral wall. And 5 hours post PCI, it's almost back to normal, except, of course, for the inferior wall, which is actually Q wave, there's not much you can do about it. That's the infarcted wall, wherein there's damage or dead tissue already. So when you do digitization from the patient with a chest pain, then the ambulance will be able to do the ECG, which is transmitted via Wi-Fi or GSM, and the hospital emergency room department receives pre-hospital notification. They are immediately prepared for fibrinolysis, or the cath lab is immediately informed and opened and has giving you faster treatment, better treatment for the patient. So you have the right technology, you have streamlined workflow and faster treatment for your patient. And this actually helps in reducing the door balloon time to from 90 to 60 minutes. Although, of course, in some areas, it would probably depend also on the traffic, but at least, every bit of help counts. Now, in addition to improving patient outcomes, let me tell you about a case study on Asperus Heart and Vascular Institute in Wisconsin, USA, when before they had the integration, they had difficulty because they have different devices, ECG devices. They are having it in different locations, like the emergency room with different connection to the hospital information system. They are looking for ways to increase their efficiency, the accuracy of their readings, the quality of their treatment care. And of course, they wanted to have faster diagnosis and decision making after their integration, their digitization, so to speak. They have increased their turnaround time for ECG and stress reads from 2 to 3 days to less than 24 hours with an ECG read interpretation, often within 1 to 2 hours. I have personal experience on this. I'll tell you a little about this later, that it's really a great deal from a 2 to 3 days turnaround to 24 hours and ECG reads within 1 to 2 hours. Now, as far as pre-hospital support is concerned, of course, since they are able to transmit via Wi-Fi, uh, they're able to help the emergency medical services, and especially people from the remote communities. They have actually reduced their door to balloon times to less than 30 minutes. Good for them, especially, but of course, in our area, we have to take into account our traffic conditions. They have improvement in their revenue protection, of course. So I'd just like to talk to you regarding our experience in my hospital. I mean, I don't want to claim to be that old, but unfortunately, in the late 80s, early 90s, I still had the chance to use a single channel ECG. And yes, we use the scissor to cut them up so that they will be able to be pasted into the ECG form. And we were lucky when our section chief bought us a cutting board so that it'll be faster to cut them, okay, into these little pieces. And we were ecstatic when we got a specific ECG cutter. We just slip it, cut, slip, cut, so that we're able to cut them faster. And then, of course, finally put them inside the ECG form. And the most, but not the least, the most important thing is our ECG ruler. Nowadays, you don't leave home without your cell phone. We do not leave home without our ECG ruler. I mean, this is very important. Otherwise, oh my God, it's so hard to compute for the intervals. But this makes our job a lot easier during that time. And finally, as I said, 2 to 3 days later, the final result when it's printed in a piece of paper and then given to the patient. So with digitalization from paper, which goes through a lot of steps, it becomes simple, wherein from the hospital information system, you have orders, it is transferred to the Muse system, and then it goes directly to the ECG card, and then you acquire the ECG, and it is automatically uploaded back to the Muse system, wherein the cardiologist can view it anywhere. Usually we view it in our heart station with our ECG uh, uh, viewer workstations, and then it can be distributed to the care or heart station unit. It can be transferred or distributed to the referring physician. It can be transferred to the report distribution to other concerned doctors. And of course, importantly, the billing info and results goes back to the hospital information system. So it makes everything so efficient and increase productivity. So it actually bridges the gap, data that you need, the workflow that you want. You can view, edit, confirm, and route. You can use a web browser base. You're not tied to workstation. Although to be honest and frank about it, I still have the tendency to use the PC or a laptop because it's difficult to be measuring using a iPad. Although most of our EPS experts use an iPad just to view the arrhythmia and be able to give uh, recommendations on how to treat the patient. But for us to interpret and type in the result, we still would want to use the calipers. I'll show you an example of that later. So now let's go to the more or less something about our present situation, which is COVID-19 and cardiovascular disease. We know published and anecdotal reports confirm cases of acute heart failure, cardiac arrest, myocarditis, and myocardial infarction is linked to the coronavirus. And actually, most of our patients do develop myocarditis. A little less than 17% do develop abnormal arrhythmias, and it has actually a high fatality rate for a flu-like problem. For a virus, I mean, 10% is actually similar to myocardial infarction, okay? And to consider that COVID-19 is supposedly a flu virus. So it's a very high fatality rate. Uh, of course, it's very important that we confirm the diagnosis of COVID-19 because we must protect ourselves, wear masks or proper PPE when we do the ECG. And as far as ECG is concerned, we do ECG on all patients with COVID. I mean, in the past, if you have a 19-year-old coming from for pneumonia, I mean, who would do an ECG on a 19-year-old? But if that 19-year-old has COVID, 100% we do a baseline ECG because we know the coronavirus attacks the heart and we want to be uh, on our toes to see if the patient will develop myocarditis, if the virus will attack the heart and not only the lungs. Okay? And during that time, that was March, April, May, we were trying whatever drug that could work. Okay, we were giving macrolides, third generation quinolones, even chloroquine or hydroxychloroquine. We were grasping at straws because we don't know much about the virus, and we know these drugs produce uh, QT prolongation. Okay, so much so that we need to do baseline QTC checking, and we need to check for the potential of prolonging of the QT interval. And of course, we discuss with the patient who is receiving any QT prolonging medication, the benefit and risk of these medications based on the baseline risk, based on the perceived or actual benefit of the therapy, and when they do develop QT prolongation. And studies have shown, or a systematic review have shown that actually hydrochloroquine did produce QT prolongation in approximately 10% of the patients. The QT prolongation usually occurs on the first 2 to 3 hours after the dose. The QTC increases up to 500 milliseconds, or there's a change in the QT interval of greater than 60 milliseconds. So much so that you need to reevaluate the risk versus the benefit of the medication. So you need to recognize the risk for developing these changes. You may opt to discontinue other QT prolonging medications. Of course, you need to correct other problems like electrolyte abnormalities. You may consider placing the patient on telemetry to be on top of the situation if in case the patient does develop QT prolongation. And if there is a significant QT prolongation, you may be obligated to stop the drug. So as far as our hospital is concerned, during that time of hydroxychloroquine treatment, it was a hectic time for us ECG readers. And we had a recommended evaluation of doing a QTC rhythm check by using just the limb leads. After all, actually, it was very difficult to do a 12-lead ECG when the patient is on the prone position. And plus the fact that, I mean, we need to admit the fact that when a nurse or a doctor goes into a COVID patient, they want to stay as short as possible near the patient and be out of that room as soon as possible. Because during that time, everybody was so fearful. So we developed this check, we call it the QTC rhythm check, wherein we just use the limb leads, just put the 4 limb leads and do a rhythm check. Of course, you must have a baseline 12-lead ECG, and then we do the rhythm check 2 hours post dose, which is twice a day, because hydroxychloroquine is every 12 hours, and we do this for 2 days. Actually, it's up to the clinician using their best judgment when the ECG will be done. So, what was the role of digital workflow as far as the management of COVID-19 patients is concerned? Of course, we had to use, I mean, of course, gone are the days of the ECG rulers. We had to use the calipers to accurately measure the QT interval. And this is one case. This is a 68-year-old male came in because of COVID pneumonia, so COVID positive. He was actually enrolled in the Solidarity trial using the treatment of hydroxychloroquine. Um, and he, if you just bear for me for a while, I need to start the video. Okay. Uh, you click on the ECG, you click on Zoom, and then move on the region of interest, click on the caliper. It will show you the caliper. You move the caliper to the region of interest, which is basically, we usually use rhythm lead 2. You click on QT interval duration, and then you move the caliper. Okay. It's actually difficult. I was doing this in my laptop. It's a little difficult to do it on a trackpad. It's easier with a mouse on the PC. Okay, you see the measurement is already 400. So you see there 400, and the new QTC is now 462, which is what the reader, ECG reader, uh, noted that the QTC of the patient to be at 462. So that's how we got by of reading it quickly and being able to compare it to previous uh, QTC lead checks for this patient. So we do know that both chloroquine and hydroxychloroquine may inhibit the SARS-CoV-2 in vitro, but accumulating data have suggested that they do not provide clinical benefit. They did not improve the 14-day clinical status or the 28-day mortality compared with placebo. So much so that the treatment arm was terminated early because of this lack of benefit. As you would remember, the Solidarity trial was done or initiated by the WHO and its partners to find out what was the effective treatment for the COVID-19 virus. It had over 12,000 patients in 500 hospitals in over 30 countries. And they looked into remdesivir, hydroxychloroquine, dapinavir, and interferon. Unfortunately, and they wanted to look at mortality, need for assisted ventilation, and duration of hospital stay. Unfortunately, during the interim results of October 2020, they noted there was little or no effect as far as these 4 drugs is concerned. And at present, so far, only corticosteroids have been proven to be effective against severe and critical COVID-19. But we actually do not have an exact treatment on the virus or against the virus. So let me summarize now on the benefits of digitization. Actually, digitization is the conversion of analog to digital, which is what we did from an ECG paper to a computer-based ECG, okay? But that I showed you earlier as far as my experience in our hospital. And digitalization is the use of digital technology and digitized data to the impact of how work gets done, how it's transformed, or how it engages and interacts. And for us physicians, we do get better ECG comparison. It streamlined our processes, improved our efficiency and productivity. And most especially, it gave us better treatment and management for our patient. For the hospital, of course, they gave us faster turnaround. Besides the streamlined processes, of course, it enhanced their billing and payment process. And in as far as the patient's concerned, they had their results quickly. And most importantly, they had better treatment and management, as I've shown earlier in the previous slides in comparison of the ECGs. So I think that's my last slide. If you have any questions or clarification, I'll be happy to answer them. Uh,
Thank you very much, Dr.
Back to
Bautista.
you, Doctora.
Thank you, Dr. Bautista, for the very interesting presentation. I have a few questions here already from our participants. I think the most interesting question that I can see here is from your experience, what is the biggest challenge when transferring paper based ECG to a digital solution? So what was your challenge when you were transferring from the paper based technology to the digital ECG system?
Oh my. Actually, that's a lot. Do you want to qualify the question? There's there's several factors that you need to consider. They want me to tell them all.
Maybe
ah,
from the clinician's perspective, was it very difficult to learn how to use digital technology
ah,
compared to just cutting it?
okay. Okay, that's a good question. On the clinicians for aspect, so in terms of learning how to use the PC, the mouse, of course, for the younger individuals, it was easy because they're used to PC. For the older ones, which I hope I don't belong, for the older ones, they had difficulty. I mean, we admit because they're not used to computers. But in terms of learning curve, hardly. Okay, because you see the ECG on the screen as if you're holding the paper. Okay, and if you want to use the caliper, you need to remember you go on the left side, click on the caliper, and then you measure, and it will automatically put that number into the blank on the upper part. If you want to type in your interpretation, you just click on the box, interpretation box that I showed earlier, and then you type. And actually what I like also with our system, they have what we call statement library. You see in the past, okay, background story, in the past, when we read the paper ECG, the doctors doesn't like to write statements. They like to write shortcuts like we call ACS, but actually it should be acute coronary syndrome, right? So when they say normal sinus rhythm, they won't say normal sinus rhythm, such long words to write. They just say NSR, right? And then the clerk knows what NSR mean, and she will type normal sinus rhythm. Now the system has a what we call statement library. You just type NSR and it will automatically type for you normal sinus rhythm. And I did a lot of that, considering, let's say, I'm techie or I want to do it. I did a lot of that for our consultants. So I have NSSTW for non-specific STT wave changes. I have AFRBR for atrial fibrillation with rapid ventricular response. So instead of writing all those words, you have shortcuts. So it's really very easy. So on the clinical aspect, I think it's only a mindset, a mind change. And admittedly, our elderlies, the old ones who doesn't like to type, either they write their findings on paper and the fellow or the resident will type it on the computer, or somebody else will type them and he will dictate. But most of us, we type it directly on the computer. It's no, I mean, one would say, where have you been all my life? It's so easy. I mean,
Okay.
that's on the clinical side. But there
Uh,
are problems, of course, on other aspects.
did you receive any pushback from let's say from the hospital administrator before you had the digital system? Was it very difficult to convince the hospital? Did you have pushback from the other doctors who wanted to stick with the paper? I want to hold this so that I can see that I'm monitoring the ECG.
From doctors, no, because the doctors immediately saw the convenience. And actually, as I was saying regarding the elderlies, since they were dictating it and somebody was typing it for them, it became easier also. So from the doctors, we had no problem. Would I say from, okay, I'll say the truth. Yes, we had a hard time from the admin because admittedly the system is costly, but I knew already that they were going to disapprove the whole system. Okay. So what I did was I bought the system piece by piece, face by face. So they never knew I was buying the whole system actually. So I did not meet that much resistance because since I was buying the system piece by piece or face by face, which is cheaper rather than the whole system uh, in one acquisition, they did not feel the expense immediately. It was only later on when they found out, huh? We bought the whole thing. Oh my God. But once they see the turnaround time and the increase in volume, I mean, I, I'm not lifting my bench. During the paper type, we usually do 50 ECGs a day. But when we had this system, easily 300 a day to 500 a day ECGs. And a paper type cannot cope with that, definitely. So they saw already the value that, I mean, there's bound to be increase in income there at 300 ECGs a day. There's increased income there. So they eventually agreed to the expenses, of course. But that's how I did it. I chopped up the system into bits and pieces and gradually uh, build them up.
Very good advice for other doctors on this call. So, Dr. Bautista, I wanted to ask you a while ago if digitization will be a very good investment for the hospital, but I think you have answered the question already. There is one question here related to COVID 19. The use of QT prolonging drugs has been debunked already. So, beyond measurement of QT prolongation, what are the other applications that you see of using Muse in the management of COVID 19 patients?
Oh, uh, well, as I was saying earlier, the serial ECG comparison is for me the best thing that happened. Putting it another way, although I'm not espousing it, but the elderlies eyeball the QT duration, okay? And I don't uh I mean I don't contend on that, but the serial ECG comparison is such a big help for us that even if we don't measure the QT, considering that we don't give, although we still give QT prolonging medication in terms of macrolides and, for the treatment of pneumonia, because there could be bacterial pneumonia together with the COVID. But anyway, despite the fact that we don't do QT, uh, remember I said earlier, we do a QTC lead check or rhythm check. We don't do that anymore. Uh, but the serial ECG comparison is such a big help. It really made us treat the patient aggressively because we can see the ECG side by side immediately. Imagine if you have a paper-based ECG, wherein you would have to say, hey, where's the other ECG? let me put it together and I want to see. You would have to flip the chart or wash it if that previous ECG has been brought down to the heart station to be read already. You would have to ask it again and be brought back. So many things could happen. Okay. But here you just open the screen. Well, of course, you need to log in because there's a password and you can see them already side by side. Well, actually, it's one on top of the other. You can already see them. And not only that, although I don't rely too much on it, the computer algorithm actually also makes a comparison. Okay, so from that alone, you already have an idea what happened on the present ECG compared to the previous. But like I said, I believe in myself better than the computer. So I still check, okay? The computer algorithm is very good, but I still check. I sleep better if I check on it rather than just rely on the computer. But you already know it. You're already being able to compare uh, like baseline ECG, 19-year-old baseline ECG. Some of us actually wouldn't even look at the ECG. I mean, what would you see in a 19-year-old? But if you repeat it a day or 2 days later and see that the patient is actually developing myocarditis already, uh, ST segment changes, so probably myocarditis, pericarditis coming from COVID, that's a good serial ECG comparison already. So it's a very big plus or a very big help for us doing the comparison. Not just the QTC. Well, I use the example of the QTC because honestly, during that time, oh my God, our system in the hospital, I go to the heart station before my clinic and read as much as I can. Then when it's my clinic time, of course, I go to my clinic. And after my clinic, I go back to the heart station and read again. But during the pandemic, the March, uh, April, May, June, during that hectic period, we had to change our schedules wherein somebody should be there in the heart station to immediately read the ECG so that when they see the QT prolongation, they'll be able to tell the attending physician so that they'll be able to prevent the intake of the next dose. Okay. And of course, changing of schedules, it's difficult. Uh, uh, that's why it's really very hectic at that time. And that's why I know how much it helped us using all these things, all these features available for us in the system.
So, Dr. Bautista, did Muse help your staff have less exposure to COVID? And did it significantly bring down the time period of taking the ECG and then getting the reading of the ECG for your patients?
Well, let me put it this way. During the time background, okay, during the time of paper-based, you take the ECG, they bring down the ECG to the heart station, they cut it up, we read it, and then they bring it back to the ward, to the nurse station. Okay? When we had this system, of course, they have to go there again to take the ECG. It's automatically transmitted to the system. We read it, and the result is automatically transmitted back. So the technician actually sees the patient only once during the first acquisition. Unlike in the previous, they do the ECG, they go down, cut the ECG to pieces, and then they go back up again to give the result. So it really streamlines the process, improves efficiency and productivity. In terms of exposure, of course, in the COVID ward, nobody actually is allowed to go there. Uh, every time you enter the COVID ward, you're supposed to wear level 4 PPE. So when we go there, uh, uh, the ECG is done in bulk, meaning all patients in the COVID ward. Okay. But the good thing regarding uh, ECG transmission is as soon as one is done, it's transmitted down because it can be transmitted via Wi-Fi to our server. We can read it, so it doesn't need to wait for the technician to go down and download the ECG. Well, of course, there are times wherein the Wi-Fi is down, but generally that's how it works. The technician does the ECG and Wi-Fi, it's transmitted down to us. And by the time the technician comes back to us in the heart station, all the ECGs there already in our server, and one of us is already starting to read it. Okay.
Okay. We have one more question here. Is your
Hmm.
Muse integrated to an EMR or a cardiology information system so that you have access to all patients' cardiac exam?
Oh, uh, I don't think Muse is designed to be integrated to other cardiac exams, meaning Muse is purely for ECG. Okay. There's a different system to put the ECG together with if you want CAT exam or echo exam. It's a different system. I forgot the name, but anyway, it's a different system, an enterprise system. But Muse is for ECG. So no, we're not connected to the other cardiac exams. Okay. Um, no, we're not connected to our hospital information system right now, because actually we're in between changing our hospital information system, because something's wrong with our hospital information system right now. So right now we're not connected. Uh, but when we were, it was, I mean, no problems, because the demographics, the data is automatically transmitted. Right now, the system is uh, the we call it billing or charging is transmitted to us, and then the technician goes up, and then the technician or the ECG card automatically downloads the ECG to the server, ECG server. That's basically the system now. But we
Thank-
will soon be connected to our EMR. We're in between transition of changing into a new EMR.
Oh, okay. Are you able to view your Muse system from home right now, or only in different areas of the hospital?
Uh, yes. Well, first of all, yes, I made sure that the ECG is viewed in that's local area network in all over the hospital. That's local area network, because we need to see the ECG in the nurses station to be able to do the comparison. But that viewing is what we call web view, which is just viewing. Okay, we have what we call a Muse editor, wherein we can interpret and type. Yes, we can do that then also. I can enter through the hospital system through VPN, which is most of the time what I do now because of the pandemic. I mean, to be honest and frank about it, I also don't want to stay that long in the hospital. So yes, I connect through VPN uh, to get into the Muse system to be able to read the ECG. Yes, we're able to do that.
There is one interesting question here, but I'm not sure if you will be willing to answer, Dr. Bautista, because you mentioned that when you were still doing the paper ECG, you could do about 50 a day. And then when you transferred to the digital system, you were able to at least do 300 a day. How significant is the increase in the revenue of the hospital? So maybe this is being
Me,
asked by a by a hospital owner on this call.
no, honestly, how should I put this? I mean, just do the math from 50 times, let's say $1 to 300 times $1. I mean, that's significant. Um, Admittedly, of course, I cannot tell you the whole amount of the system. I also don't know the whole amount of the Muse system, but admittedly, there would be a return of investment over time. I mean, it doesn't recoup itself in 1 month, of course, but definitely it will recoup itself because in a paper-based ECG, remember the single channel? How fast can you do one, and then how fast can you cut one? Okay, unless you have a factory of workers and several single channels and they're all lined up and the patients just line up, which is so inefficient. And if you have an ECG machine capable of doing the upload, after doing one, it's uploaded, you connect it to another patient, it's uploaded, connected to another patient. That's the only thing you do. Connect, upload, connect, upload, connect, upload. So it's bound to really give you a return of investment. But just to make a simple math, 50 ECG times $1 is a lot of difference between 300 ECGs times $1. It's a lot of difference. But definitely we were able to do a lot of ECGs, as I said, connect, upload, connect, upload. Unlike before, okay, we connect and do ECG and all the ECG papers are just on one side. Then we have to stop working and cut them all up. We cannot admit more patients to do ECG because all of them are cutting all the papers. So it's so inefficient. That's why we cannot do more. But with the digitization, we can actually do a lot. And there's also one more problem. Uh, there came a point wherein I'm sure you know the heart station. It's one room with the ECG, and okay, the ECG room is one room with ECG. The heart station is another room with an echo, another room with this, another room with that. Our ECG paper, the patient records, actually occupied 3 rooms already. And that's paper. And we told the admin, if we remove all these papers, meaning put them into hard disk, so just scan them, photocopy them, scan them into into PDF, and we are going to free up 3 rooms. We can put 3 treadmills or 3 echoes or what. We can still increase income in those 3 rooms. So it really makes sense. But of course, it takes a lot of work trying to convince the MBA people. I mean, sometimes they also have a lot of things to think about.
Dr. Bautista, do you think Muse can help your cardiac patients to reduce the length of stay in the hospital?
Oh,
So by
yes, definitely. Definitely. Because as I showed you early in my example, since we saw already the changes happening, we were already able to adapt or become more aggressive in treating the patient. unlike, I mean, again, I'm not admitting to being that old, but there were days wherein I have to get the old ECG. Oh, where is it? I want to compare. Am I going to change my management, or am I just going to monitor the patient? I have to, wait for it to come so that be able to compare. Especially, admittedly, most, well, sige, most of our patients are, they sort of refuse major treatment like PCI because it's expensive in our place, in our area. So it's difficult to convince them, let's do this now. But when they see that the ECG in front of them is changing, because we can show them the iPad. Okay, look, the ECG changes. So they're convinced sooner rather than later. And we're able to treat them properly. And of course, for me, the most important thing, I'm able to sleep better at night rather than worrying about them.
Since you mentioned a lot of benefits of the digital ECG system, there is a question here. Will your hospital be considering multi-hospital integration of your Muse system? Do you think that will help?
Oh, definitely. Uh, uh, how should I put this? Unfortunately, okay, I'll tell you the truth. We have, I think we have 50 satellite clinics, but unfortunately, in some of those clinics, the ECG machine is not compatible. Okay, granted. But all our halters in those clinics are compatible with the Muse system. So that's the first thing that we're going to enable to centralize Holter monitoring interpretation. Because in the past, what they do is they'll do the Holter, or the patient will go to the clinic, attach uh, the ECG, the system, etc. Of course, go back to the clinic again and remove it the next day. And then somebody, a rider, a courier, will bring the the recording to us. We'll print it out and then we read it. Paper based. We'll read it and then we'll type it, and then a courier will again bring it back there to that clinic, wherever it is. So that's 2 to 3 days turnaround time again. But once we get to be connected, which by the way, we are in the process of doing interconnection of the halter, uh, uh, the halter data will be automatically transmitted to our server. We will read it online, and the result will be automatically transmitted to them. All they need to do is just print the paper, the report paper, and then give it to the patient. Again, easily 1 day turnaround time. Everybody would be happy. The clinic who earns the income for that, the patient, and of course the doctor. Everybody would be happy. But with ECG, I admit there's difficulty in centralizing the ECG because they have different kinds of ECG that we need to make it compatible first.
Thank you very much, Dr. Bautista. I do not see any more questions from our participants today. You have one more chance to type in your questions now. But if there are no more questions, I think um, we are okay for today. Uh, thank you very much, Dr. Bautista, for
Thank you very
sharing.
much also for this opportunity to be able to speak to you.
Thank you. I think this is very exciting. We learned a lot of tips from you. One of our participants is saying thank you very much. Thank you very much, Dr. Bautista. And to everyone on this webinar, thank you so much for joining us tonight. Enjoy the rest of your evening.
Okay, thank you very
Thank
much.
you. The link to the next webinar is attached in the chat window. So, in case you want to join us for the next two webinars in March, just click on the link to register.